Now I invite Dr. MAMTA Singh, who is assistant professor at Rajkot AIMS, for delivering on talk on corneal topography and clinical implication. She is again one of the leading corneal surgeon, was working with us in Bihar and now shifted to Rajkot at Rajkot AIMS.
Thank you, sir. Thank you, AIOC, for this opportunity. I will be talking about corneal topography. We all know that refractive surgery has come up in the very big way in our market, but it's very important to know when not to operate. That is where the exact catch is. And for that, we need to know the basics of topography. So topography is basically the science of describing or representing the feature of a particular surface. And mainly we have two types of topographers in the market. One that just does the surface topography. It will just talk about the surface. And next, that will talk about both anterior as well as the posterior surface. So they are mainly based on Scheimpflug camera or Scheimpflug based devices they are. So if we talk about the placido-based system, the idea here is we will be using a series of concentric illuminating ring, and we will be reflecting it over the surface of cornea, and then we'll try to analyze the size and distortion of this ring pattern. But the limitation here is we are not looking at the posterior corneal surface. So obviously, we cannot talk about the pachymetry value here. And the second thing, at periphery or even in the center where exactly the camera reflection is, the data are not true data. They are mostly extrapolated data. So at those places, we are not actually working on true data. But if we talk about elevation-based topography, it talks about all the three coordinates, X, Y, and Z. But the problem here is if we talk about the surface topography here, and if we compare Placido versus this Scheimpflug devices, at least the accuracy is limited here. And that is where the concept of integrated topographer came into picture, where we do the surface analysis with the help of Placido-based devices and the posterior segment analysis, in the posterior part of the corneal analysis with the help of Scheimpflug camera. We had ARP scan also, which works at a different principle, but mainly we are going to talk about Scheimpflug devices here, mainly Pentacam. So they consider nearly 25,000 true elevation point to give the actual picture of corneal surface, and even the finer movements of eye, they get negated because of presence of a second camera. And if we go through a typical topographic map, it has got two parts. One on the left side where we can see certain digits, and on the right side, we can see certain color-coded maps. So if we start from the left side, from the top, it is patient information about the corneal front surface, back surface of cornea, pachymetry information, and then info about the other parameters. So starting with the patient information, we need to know when we are doing this topographic scan, what is the date of birth to compare it from the normative data, and similarly, which eye is being done. Then comes the corneal front surface. Before analyzing any of the topographic map, we need to be sure about the quality of specification, whether the scan quality is okay or not. So this has to be decided. Then the Q value, basically it denotes the shape of cornea. Normally it is between 0 to 0.5, it's in minus. Then comes RH. This is horizontal radius of curvature in the central 3 millimeter of cornea and the corresponding K1. This is vertical radius of curvature and the corresponding K2 in the central 3 millimeter. This is mean and the corresponding K mean. What is the amount of astigmatism on the front surface of cornea and at what axis? What is the peripheral radius of curvature where we are considering 9 millimeter of cornea? And what is the minimum? If suppose a particular portion of cornea is bulged, then probably the R mean would be different and our mode of action would be different in those cases. So we have to pay attention at this R minimum. All these values would be similar. They will be represented in the similar manner on the back surface of cornea also, but the difference would be the power map would be in negative. The reason being the posterior surface of cornea, because of the difference in the refractive index between cornea and the aqueous, the rays are actually getting diverged. So it will be in minus. Then comes the pachymetry map. Mainly we check the location of three points. One is the pachy apex, that is how much is the thickness of cornea at the corneal apex, and we take it as coordinate 0 or the point 0. And then we try to know how far is the pupillary center and how far is the thinnest location of cornea and what is the thickness at them. So mainly we are checking thickness at pachy apex, pupil center, and the thinnest location. Other parameters like chamber volume and cornea volume. Cornea volume is important in cases of keratoconus, but the exact, the cutoff has not been clearly defined for Indian population. Chamber volume is very important when it comes to phakic IOL. Keratometric power distribution, again, we check the power between anything value, value between 1.5 is lesser than 1.5 is normal. What is the angle? How much is the AC depth? And AC depth is again important for phakic IOL and pupillary diameter. Then if we shift towards the right side of the map, we have this color-coded map. And this color coding is based on Louisiana State University color coding, which talks that the cool colors, the violets and blue, they represent flatter cornea. The green and yellow, they are normal portion of cornea. And warm or hot colors, they are basically representing the steeper meridians. So if we talk about a simple, the typical representation, then we have on the top left, we have this sagittal map, then elevation at the front surface of cornea, elevation at the back surface of cornea, and the corneal thickness map. This sagittal map is something like we are looking at the cornea from the front, right from this, this axial view. So anything like which is very much abnormal is going to be apparent here. So if like finer details we cannot decide based on the sagittal map. If we want to read one particular point in details, then we need to take this tangential map where every individual point is considered in details. Then the corneal thickness map, as I said earlier, there would be 3 points where we normally check it: the pupil center, pachyapex, and the thinnest location, and location of one with respect to pachyapex. Then comes the corneal thickness spatial profile. Here what we do, we take the thinnest portion of cornea, then we draw 22 concentric circle around it. We check the pachymetry, the average pachymetry on individual circle, and then we draw it from the center to the periphery. That is how the entire thing is done. The patient's value will be represented in red color. The normative value will be represented in interrupted black line. So it is important to know whether the pachymetry value is lying within the normal limit, plus whether this progression from center to periphery, this is progressing in the normal manner or not. That is also important. For example, here we have a case where although this is well within the normal limit, we can say the corneal thickness is between 400 to 600, but we can see the center cornea is almost as thick as the peripheral cornea is. So this was a simple case of corneal edema. That is the importance of the CTSP graph. Then comes the most important map, that is the elevation map. Elevation map talks about the given cornea in reference to a reference body, which is actually machine generated. Normally it is taken as sphere, but in cases of very irregular cornea, astigmatic cornea, we can choose ellipse or toric ellipsoid also. For example, if this is a cornea and this is the reference body we have, we can see that there is one point where the cornea and the reference body are at, they are touching each other. So this will be point 0. Any portion of cornea which is below this reference body would be demarcated as minus, and the portion which is above this reference body, that will be denoted as plus sign. That is how the things work. The most common algorithm which is used is the Bellin-Ambrosio algorithm. They take or they analyze the central 8 to 9 millimeter, and they choose best fit sphere as the reference sphere, and the scale is varying from plus 75 to minus 75. So in comparison to the reference surface, if the anterior surface of cornea is elevated less than 12 micron, or if the value is less than plus 12, this is normal. Between 12 to 15, this is suspicious, and more than 15, that is keratoconus. That was the original algorithm. Now we have this revised algorithm, also the enhanced ectasia scale. So if we talk about some normal pentacam value that we consider in usual scenario, but case to case it may vary. K reading for refractive surgery, normally we take 48. And if we have very finer blades, probably one can go for 49 also. Corneal astigmatism less than 6 diopter gives better, quality of vision also has to be maintained, because beyond that, probably the shape of cornea would also change. Thinnest location, even for PRK, better to have the lowest value of 470. Within the 4 millimeter circle, the anterior elevation should be less than 15, posterior elevation should be less than 20. If the superior is steeper than inferior, then the difference has to be less than 1.5. If the inferior is steeper than the superior, the difference has to be 2.5. And the superior inferior packet difference should be less than 30. These are the normative value that we talk about. So if we talk about this scan, we can see here that nowhere the value is like reaching 48, 49. Anterior elevation seems to be pretty fine. Posterior elevation again less than 20, and the pachymetric value appears to be normal. And the quality of scan is obviously it is okay. So this was a normal corneal topography. Next scan, if we see it here, here we have 45.9. And here we have 44.4. So 1.5 diopter of astigmatism is there. And we can see this axis is steeper. The vertical is steeper. But elevation is normal. On the posterior surface also in the center, it is normal. And here we can see the pachymetry value is normal. So this is simple, a case of with the rule astigmatism. If we talk about this case, what we can see it here, this appears to be normal. This also appears to be normal. Nowhere it is more than plus 12. But here we can see at this particular point, this is plus 20. But if we correspond it with the pachy, we can see the pachy is normal here. So this could be an early case of ectasia. So particularly in these cases, we shouldn't exactly jump for the surgery. Probably we need to follow up these cases. This was a case where we can see everything is going wild. It's like, keratometric power is again very high, anterior and posterior elevation all very high, and we can see the pachymetry value is very less. So this was a clear-cut case of keratoconus. So with this, I would like to conclude. Thank you so much, sir. Thank you for this opportunity.
Thank you, Dr. Mamta. So any guideline about when one should order for this topography in young kids? Because these are the patient of early
Yes, sir.
keratoconus.
We are seeing more number of vernal keratoconjunctivitis cases these days, and they have this tendency to, continuously rub their eyes. So if there is change in glasses, if the cylinder is more than 2.5, for me it is 2.5, but if you go theoretically more than 3 diopter of cylinder, then it's better to have a baseline packet done. It will cost probably 1,000 rupees to the patient, or 1,000 or 1,500 rupees to the patient. But once we have this baseline packing, and if there is a change of glasses, say more than 0.5 or 1 diopter in say 1 year, then I would definitely like to follow up these cases with the next packing. How much there is a change? Because when we talk about early C3R, in these cases, pediatric cases, our thresholds should be really lower. Because I have seen a 9-year-old kid also going for high drops. So in these cases, we really need to be on our toes. Pregnant female, C3R, these pediatric keratoconus cases, we need to go for early topography, sir. That is for sure.
And these topographers are usually coming with some other modalities of evaluation of anterior surface, like tear film and other thing.
Yes.
Is that going to add on with the information, or they are just of mathematical value?
No, so definitely anything which is going to be, give information about the surface particularly, that is going to be there. Because we all know that dry eye, in addition to any of the allergic disorders, they are like going to be the added hazard over the ocular surface. I think AIOC Patna has got one serious with dry eye module, I guess, yeah.
You want to say something, Dr. Rakhe, on what added information that those regarding the aqueous film and tear surface it is giving?
We have serious photographer, and in that machine we have non-invasive scale and we can measure it easily, as well as micrography we can do. So in the patients where suppose there is a dry eye, and these dry eye patients usually sometimes it's difficult to do the Shamas test or fever time on slit lamp. So these patients can go for non-invasive as well as the topography at the same time. And sometimes dry eye patient usually gives very fallacious result on topography. So better to put 1 drop of lubricant and then go for it.
Even if you talk about DUEs too, sir, the ideal is non-invasive TBUT. That is what they talk about. So in that way, it's definitely going to help there.
The Cirrus is helping because it has got both the things, the Placido disc as well as the simpler camera.
Integrated, yes.
That is the advantage point here. So it can very well map the anterior surface, the tear film, mebography, even the pupillography it can measure. And even the lens power kind of thing, all can be done with the same machine.
The same system is there with the Galilei also, sir.
Yeah.
That is also
Yeah,
wonderful.
Galilei has both.
Both. Yeah. Thank you so much, sir.
Thank you, Dr.